Welcome to the NewlyMeds Podcast. Any views or opinions expressed in this podcast are our own and do not reflect the views of our employers or affiliated organizations. This content is for informational purposes only. Always follow your local policies, protocols, and medical direction.
What is up, everybody, and welcome back to another edition of the NewlyMeds Podcast. I first want to start out by apologizing. We've had a little bit of some technical difficulties and a delay. Dan has moved further away from me. I think it's the smell, but I can't be so sure about that. But we've been finally getting back onto a schedule. Yeah, we've finally been getting back onto a schedule. And so the plan here going forward is that we are going to have a Quik Crit on the first of every month. And then in the middle of each month, we're going to give you an hour long or close to an hour long episode. So you have 2 episodes every month, one faster and one a little bit longer for you to dive into and enjoy. And so with that being said, today we're going to jump into our first edition of Dan and I's Quik Crits. And we're going to talk about a topic that I think a lot of you are going to see a ton of interest in, some controversy, and I'm sure you've already discussed in the field. And today, Dan and I are going to be discussing the use of amiodarone versus lidocaine in out-of-hospital cardiac arrest. So, Dan, why don't you tell me a little bit more about this topic and how we're going to introduce this to our listeners?
Exactly. Well, I think so. First of all, I know one of the primary questions I would get asked, and honestly, one of my primary questions coming through medical school in general is, when we have the choice of medications, what medication are we choosing and why? When we have that discretion to pick what medication, and they're both, quote unquote effective, well, what would make me pick one medication versus the other? And I know, especially when it comes to the discussion of amiodarone versus lidocaine, I know that is one of the first ones that comes up. I think most importantly, we'll start with a quick review on what these medications are, and we'll briefly touch on some studies, and hopefully that will give you guys a little bit better footing on which direction you guys are leaning during what scenarios. So we'll start off Amio, class 3 antiarrhythmic. This one's more your broad spectrum antidysrhythmic, right? You're going to have prolongation in the action potential. This is going to prolong the refractory period. This is you're going to see a decrease in conduction velocity. Our standard typical dose for this will be a 300 milligram IV push initially with a repeat half dose. The quote unquote issue with Amio is that while it is excellent for our refractory VFibs or refractory VTACs, we can see more hemodynamic changes as far as our blood pressure goes with Amio. Which brings us to our lidocaine, our class 1B antidysrhythmic, and this is going to be your sodium channel blocker. This is going to be good in that rather than the effects that we see with Amio, we're going to see more of a shortening in the action potential, which is particularly good in ischemic tissue. And this is also going to bring us a decrease in ventricular automaticity. So you're going to have more of a suppression in that ventricular activity. Dose for this, 1 to 1.5 is what a lot of places say. However, your more effective range in that is the 1.5 milligrams per kilogram dose. And I think that is, I imagine you'll probably talk about this when we talk about studies and field practices in a moment. But I think that is one of the issues that we see, is that especially if your service is carrying just the pre-filled syringes and you are just giving a single pre-filled syringe, you're underdosing your patient a lot of times in that scenario. So make sure that we're paying close attention, that we, again, following your protocols, following your medical direction as appropriate. But if you have up to that 1.5 milligrams per kilogram, make sure that we are actually dosing these patients at the 1.5 milligrams per kilogram. Well, did you have something?
Yeah, Dan, I think you raised a great point there. And I think that's one of the things with lidocaine that I feel steers people away. It certainly does not steer me away, but one thing I hate more than anything is math. And so, like any person that goes into any sort of job or career, I picked what I hate the most, which is math, and said, I'll just do paramedicine and nursing, which involves no math, right? And then the next thing you know, they start throwing MIGs per kg, mics per kg, per ML, per everything. And I'm like, I'm doing more math than I ever thought I would do. And I took calculus in college. So at least there's no X equals whatever. But one of the things that you want to consider is what you just said, right? We need to give that 1.5 milligram per kilogram dose initially. And if for whatever reason, which we often do, we need a follow-up dose for that. And typically you're going to cut that dose in half, right? We'll go to 0.5 or 0.75 milligrams per kilogram for the lidocaine on a repeat dose. But at that point, if you're using the pre-filled or even a vial, we're running pretty much out of our lidocaine after dose 1. And so I think that that's a major problem that we run into pre-hospitally, especially on larger patients that we would see in a pre-hospital setting, to where that 1.5 milligram per kilogram is used up on just a single dose. And then where do we go from there? Are we now talking about switching medications because we're out of one? How do we continue that care? So I think that's a great point, Dan.
And just to wrap the farm discussion up here, the big key takeaways, big key differences as far as the pharmacology goes: Amio is going to be your more broad antidysrhythmic, but you do have more risks with your hypotension and your effect in your hemodynamics there. With lidocaine, it is a bit more narrow in its scope as far as its effect on the action potential, but you do have the safer hemodynamics with that, and which we'll get into after this. Lidocaine is just as effective in many ROSC and survival to admission and various trials, which we'll get into here.
Yeah, I think, again, Dan, really great point. And where I want to go with this is sort of the literature. And I urge all of you, which I've done ever since the NewlyMeds has been a podcast, is to look into the literature, which we always link in our episodes, and do your own independent research, because this is practice guiding and practice changing. So if you're going to do something in the field, I would very much urge you to have well researched, thought out processes before you throw any medication at any patient.
Absolutely.
So with that being said, with the Amio, how did we get here? Well, in 2002, there was a study. It was called the ALIVE study, and it was performed by Dorian. And he looked at this randomized trial with a shock-resistant out-of-hospital cardiac arrest. And so this is really where Amio was introduced when we get to the down and dirty. And they looked at the survival to hospital admission, not the survival to hospital discharge, but the survival to hospital admission, which means, is the patient alive when we admit them from EMS at the receiving facility? And so they compared it to lidocaine. And so this was practice changing at the time. And so it showed that there was an increase in the survival to hospital admission, but there was no long-term change in the survival or neurological study in this. They didn't really examine that. And there was no really significant change in the survival to hospital discharge. And then a few years down the line, there was the ALPS or the ROC ALPS study, depending on where you look, which was a very large randomized placebo-controlled trial. And that examined Amio, lidocaine, and then a placebo. And this study also, it was 3,026 patients, 974 in the Amio, 993 in the lidocaine group, and 1,059 in the placebo group. Again, looking at the same similar subgroups, the survival to hospital admission and the survival to hospital discharge. And so it showed that neither Amio or lidocaine had a significantly improved survival to hospital discharge with any change in the neurologic outcome compared with the placebo. And so when we were looking at these studies, there's nothing that's really pushing me one way or the other. A few of them will say that Amio creates a better survival to hospital admission. You'll see some conflicting data that says lidocaine produces a statistically similar finding, right? Where maybe Amio gives you a little bit more, but nothing that's, practice changing. And so I think the key here is to do good, strong, independent research and to understand how these medications work in the out-of-hospital setting and then with you as a provider. And so as these studies progress, and there's obviously always studies going on, we want to keep up to date with the literature. But right now, there's nothing that's really swaying me or anything that's out there one way or the other as a provider. And so when I make my clinical decisions, I start to think of what do I want to accomplish? And whenever I'm training a new provider, a paramedic, or a nurse, I always tell them to sort of address each patient in this way. What do I know? What do I think I know? And what do I want to accomplish here? So if I know that my patient's in this cardiac arrest, a VTAC or a VFib, now what do I think I know? Do I know where it's originating? Do I know sort of what caused this arrest, the etiology? And then what do I want to do and what do I want to accomplish and how do I best do that? And so for me as a provider, I think I've used probably 50-50 for both. I've used Amio in out of hospital cardiac arrest, and I've used a Lidocaine in out of hospital cardiac arrest. I probably, if I had to throw data points out there, I've used more Amio. And I think it's the exact same reason that Dan just said. It's hard for me to actually get enough Lidocaine in the back of my truck to do what I want to do with that patient. And oftentimes it comes into that repeat dosing. And so when I look at these patients, in my mind, the goal that I think about is what do I want to accomplish? And obviously, with the out of hospital cardiac arrest, we're striving toward ROSC. And so when I think of this, I wonder how do I get to ROSC and what medication is going to get me there the most? And I think that that's a really complicated answer. And Dan, maybe you have some more insight on this, but that's sort of the process that I go through in my head when I'm selecting this. And I often think about when I'm striving for these patients, I want them to have ROSC. How compromised are my hemodynamics going to be following the amiodarone administration? And so that's what I often think about is, was there CPR before I got there? Was there a known downtime? Was on my arrival a shockable rhythm? All of these things where we look at these data points with out of hospital cardiac arrest, how viable is ROSC in that situation? The patient that had a 30-minute to unknown downtime or the patient that had a witnessed arrest with bystander CPR, AED applied, and a shockable rhythm on my arrival, that patient might benefit from the lidocaine because the hemodynamics are really, really important there. It's a super fresh arrest compared to someone who has been down for 45 minutes with an unknown etiology, and they're in asystole. They might not ever even need amio or lidocaine, but that's sort of what I think about it in my field process. Dan, what do you think?
Yeah, and I think we are very much along the same line of thinking there as far as the two medications go. I know my other primary consideration is, especially if it's a post-ROSC and they have a ton of ischemia-driven ventricular ectopy, that especially when they are most likely hemodynamically unstable, I'm leaning more of a lidocaine in that type of scenario. And again, I think we could sit here for, rather than doing a 15-minute episode, which we're coming up on, I think we could sit here and, do a whole season-long series on various scenarios. I think the most important thing is to, as Will said, we'll have links to a variety of trials, including the ALIVE trial, including the ARREST trial, the ROC ALPS, and maybe a couple other articles that we've found here along the way. Take the time, do your research, pull out the pharm textbook from medic school, go back through, look at, because another thing to consider with the two medication is the half-life and the onset of action in these drugs.
Yeah.
With Amio, you do have a very long half-life, substantially longer. It could be up to weeks versus that of lidocaine, where maybe you get 1 to 2 hours of a half-life with lidocaine. So if you're trying to long-term suppress more ventricular ectopy in somebody that is more hemodynamically stable, maybe we are leaning more towards an amiodarone, right? So pull out that textbook, or it's 2025. Go on Google, pull up the scholarly articles, some scholarly research on amio, your pharmacokinetics on amio and lidocaine, and then look at these trials and make these determinations. But hopefully, at least this start of the conversation here, it's you guys thinking about that. Hopefully, these very generic scenarios kind of helps maybe steer some people that were questioning which direction that they think that they should go.
100%.
And obviously we'd love to hear from you guys just in general. Anything that we can do, certainly reach out, and we would love to continue this conversation, have some more if anybody has any questions.
So
But Will,
Dan, before we
anything?
close, let
Yeah.
me get your opinion on this, just to give our listeners and our viewers who are watching the visual of this, the down and dirty here. For me, in 1 minute, when I'm thinking about Amio or Lido, and this is how I would challenge a lot of providers to think, how are you going to manage your ROSC patient? Because that is my goal. When I arrive on scene of a cardiac arrest, my goal is ROSC. Obviously, the end goal is a good neurologic outcome, a good, survival to hospital discharge, but I want to get ROSC. And so when I'm selecting these medications, how am I going to manage ROSC? And so when I'm using amiodarone, I know that I'm going to have to be ready for probably push-dose epi, for probably norepinephrine drips, for maybe epinephrine drips, whatever you have as a vasopressor. I know that there's probably going to be significant hypotension that won't go away because of the half-life of amio. Comparative to the lidocaine that I use, my immediate concern is, do I have enough available to run this arrest for the entire duration? And those are the two huge takeaways that I have in a minute or less when I'm selecting these drugs. Dan, what's your take?
No, I would agree 100% with that. And all I would add is something that you briefly touched on earlier. What is the etiology? If I know more what the etiology is, that might lean my decision more towards a lidocaine. However, if I'm unsure what the etiology is, and I am more so looking for these immediate effects, I might go more broad spectrum and choose like amiodarone. So I think with what Will said, taking that into consideration with what our general etiology is I think a good starting point for us.
Yeah. Well, like Dan said, we would love to hear from you. That's all we have for this quick crit that we're doing now. Dan, anything else?
I think that's it. Make sure you go check us. We'll have some reels up on the Instagram, the TikTok, on YouTube Shorts. Make sure you follow us there. We might be posting more things on there that's not podcast, or it'll be related to the podcast, but not necessarily coming directly from the podcast. Podcast always up on Apple Podcasts, Spotify, and in video form on YouTube. So make sure you like us on all the different platforms and help get the word out there. And if there's, as always, if there's anything you guys want to hear from us, please let us know. We love to hear from you. We would love to do an episode on something that you want to hear about. But until then, I believe that's all we got for this quick crit. So
Catch you on the next one.
We'll catch you on the next one. Stay safe.